Welcome to Time to Talk Science and Medicine, a new podcast designed to highlight translational researchers from Queen's University, Kingston, Ontario. The main goal of these podcasts will be to focus on the researcher, find out where they've come from, what motivates them, and how their research will change the world. We also try to find out a little bit about the person behind the dangerous idea, which makes their research world-class. My name's Dr. Charlie Highmarch, and I'm a genomics researcher and faculty member at the Queen's University, Kingston, Ontario.
And my name is Dr. Stephen Archer. I'm a cardiologist, clinician-scientist, and researcher, and I'm also the director of the Translational Institute of Medicine, or TIME, here at Queen's. And it's my great pleasure to introduce my friend and colleague of many years, Dr. Bernard Thébaud, who will be talking to us today about his promising work on regrowing lungs in babies. He's a senior scientist at the Ottawa Hospital Research Institute, OHRI, and the Children's Hospital of Eastern Ontario, better known as CHEO. He's a neonatologist at the Children's Hospital of Eastern Ontario, and he provides care for critically ill, tiny babies. He's a professor of pediatrics at the University of Ottawa and holds the University of Ottawa Partnership Research Chair in Regenerative Medicine, which is quite a mouthful, Bernard.
Dr. Thébaud, thank you very much for coming on to our show today. Before we get too deep into your clinical and scientific interests, we want to find a little bit about what motivated you to become a medical doctor who gives medicines, but also a scientist who develops new medicines and new strategies to treat disease. What's your origin story, please?
My origin story starts in Munich, Bavaria, because this is where I was born and grew up. And originally, I was supposed to become a professional soccer player, and that's why
I need to, as an Englishman, I need to interrupt because I'm okay with you calling it football under these circumstances. As a European, you'll understand that.
Absolutely, and this is where I met my first mentor. He was a German national player, and he taught us everything about the art of football. And it was clear that I would become a professional soccer player. And so when I got older, around 16, my dad asked me what I really wanted to become in life. And I said, I don't know. And he said, what about doing sports medicine? And from that age on, I knew I would become a physician. And then it's about the people you meet. I went to medical school in Strasbourg, France, and through the electives, I realized that probably pediatrics would be an interesting field of medicine. And my friends encouraged me. They said, yeah, you would be the ideal pediatrician. And after an elective in pediatric surgery, it was clear that I would become a pediatrician.
So I've got to ask, Bernard, what makes the ideal pediatrician? What do you think your friends saw in you, or what did you see in yourself that made you a baby doctor?
So these friends, they had nothing to do with medicine. I think they must have seen a nice person that truly cared about people and had a very youthful mind. I never thought about this.
Yeah, I would affirm that. Maybe it was your teddy bear shirt or something as well, but yeah.
Teddy bear shirt? Sorry, I've got to pull on that thread.
He's got classy threads.
Yeah, and then throughout pediatrics, I met another clinical mentor when I did my neonatal transport training. And it was clear from that moment on that I wanted to become an intensivist, pediatric intensivist or neonatologist. And then I did my fellowship in neonatology, and that sealed it clearly.
Yes, I remember meeting you in 1996 in Paris, and you were I think at that time you were doing your PhD. And the thing that struck me about you was your enthusiasm and passion for trying to understand the neonatal lung. And here we are some 28 years later, and you're still working on that. So obviously a lot of persistence and a lot of enthusiasm.
Yeah, I came really late to research. It's when I realized that I wanted to practice academic medicine and I needed to do a master's and a PhD that I got interested into research, and I really got the bug. And that's when we met. And during my PhD, And you gave me the opportunity to do a postdoc in North America. And that's how I ended up in Canada. I realized the importance of having protected time to do research, even though I was primarily a physician. That gave me the opportunity to truly dive deep into research issues and try to find new medications to cure some diseases that today are still incurable in babies.
Yeah, and it's interesting. I remember at the time I was learning neonatology, at least amateur neonatology from you, and you were introducing me into diseases like bronchopulmonary dysplasia, the sort of chronic lung disease of prematurely born babies, and showing me what the lung histology looked like. So theoretically, I was supervising you, but at the same time, you were educating me about this entire field, which I didn't know much about at the time. So thank you. So on that note, we like to ask people that come on the podcast to tell us about their dangerous idea. And a dangerous idea means an idea that, if it's true, would disrupt the way we currently do things. So maybe, because most of us are not neonatologists, you could tell us about the clinical problem or challenge you're interested in, and then what is the disruptive idea that you're applying to that clinical problem?
Yeah, one of the biggest challenges that we have in neonatology is in babies born too early. Up to 12 weeks too early, and they often have trouble breathing. And to keep them alive, we put them on a ventilator, give them additional oxygen. And while this keeps them alive, it also causes some degree of lung injury, and which causes this disease called bronchopulmonary dysplasia, or BPD, which is a chronic lung disease where the lungs try to repair themselves, but keep getting injured by the mechanical ventilation. And so it's a vicious cycle. And so far, we have not figured out, even despite all the progress that we have done over the past 25 years, we have not figured out how to prevent lung injury or how to regrow an already damaged lung in those preterm babies. And the last breakthrough in neonatology is now 30 years back with surfactant, and ever since there has been nothing new.
And what's surfactant?
Yeah, surfactant is it's a white liquid that we have all in our deep lungs that keep the alveoli, these bubbles in the lungs, open to allow gas exchange, oxygen to be taken up, and CO2 to be released. And in babies that are born too early, that surfactant is missing. And now we can give the surfactant, and it really cures the acute lung disease. But we're left with the chronic lung disease.
So in effect, the treatment that you're giving is actually just creating a new problem that you have to deal with.
Yes, we're the victim of our own success.
And it is interesting. We were having a bunch of colleagues talk with you last night, and we had a guessing game, which you can't do very well on a podcast, but we were asking them to guess the size of your patients, because most of us were adult physicians, and my average patient probably weighs 80 to 100 kilograms. And what's the average weight, again, of your typical patient?
700 grams.
700 grams. Yeah, that's a tiny baby.
That's a tiny baby.
So that's great. So now we know about your tiny babies, and that we're sort of the victims of our own success in keeping these progressively more and more premature babies alive with ventilators and surfactant and the like. But what's your disruptive or dangerous idea?
Yeah, so the dangerous or disruptive idea is, how can you prevent the lung injury, but at the same time promote lung growth? And so here we had this idea of using stem cells to achieve this, attenuate the lung injury and regrow the lung with those cells that in theory would have the capability to get into the lung, replace the dead cells, turn into lung cells, and basically rebuild the lung.
So the idea of and what's a stem cell?
A stem cell is a particular type of cell that has the capacity to self-renew. It can make two cells that look exactly identical. And then under certain circumstances, these cells can also become any type of cell. And so the idea was that, well, if a stem cell can self-renew and then turn itself into a lung cell, we could harness the power of these cells to rebuild the lung.
And where are you getting these magical beans from, these incredible cells?
So we actually can get them out of the umbilical cord of babies after they are born. So it's very safe to retrieve those cells. And usually the umbilical cord is discarded, but here we would use it and try to extract these cells to expand them and then inject them into the babies when they need them.
But I understand from listening to your lecture this morning here at Queen's University that that brilliant idea of regrowing lung with these magical stem cells worked in one level, but was not quite what you expected.
Yeah, absolutely. So we thought that they would rebuild the lung by replacing the dead cells, but when we look for them, we can't find them. And it turns out that these cells work through a completely different mechanism. They basically come into the lung, look at the mess, and try to then coordinate the repair response. And they stay there only for 2 or 3 days, and then they disappear. And so they basically act like paratroopers trying to fix the damage, and then they retreat.
It's like the ninja that hits in the middle of the night and does something, and then the ninja's gone, but the results linger on. So very interesting.
Perfect. Well, thank you very much for the kind of the higher level explanation of the research. I'm sure will resonate with scientists and clinicians, but we also like to make this super accessible. So how would you explain your research to your average high school student so that they understood what you did?
We have the challenging task to protect a very fragile lung from becoming injured from the treatments that we use to keep those babies alive. And these tiny cells are building blocks of the lungs, for example. And by giving these cells to the tiny injured lungs, we had hoped that those building blocks, like Legos, would rebuild those tiny lungs. And it turns out that this is absolutely not the way these cells work. They get into the lungs, but then they don't stay there. They just look at what is happening, and then they try to dispense important factors for repair or for dampening, taking away the inflammation that is causing some injury in those lungs. And then those cells retreat and can't be found.
So that's a really, really clear explanation of your research to a high school student. But it strikes me that when you're explaining this as a clinical therapy, you're not explaining it necessarily to sort of calm individuals who are sitting in a kind of a nice studio. You're actually dealing with parents who the worst possible time in their life with the worst possible things happening to them. How on earth do you communicate this relatively complex therapeutics to parents who are scared, afraid, and they don't know what's going to happen? How do you get this message to them so that they can adequately consent for this treatment?
Yeah, thanks for this question. This was a beautiful new project that started that we hadn't anticipated we would do. But as we were getting closer to starting a clinical trial, we had exactly that question. And we wanted to put parents at ease to make sure that they understood why we were doing this and that there was a very promising therapy. And so we came up with the idea of making an animated informational video for parents. And this was really, I think, can be a game changer for informing parents to participate in clinical trials. Every time I met these parents after they had seen the video, they were so well informed and had very targeted questions. And one of the biggest problems in clinical trials is lack of enrollment. And here, by doing this very simple informational 5-minute video, we have new tools to avoid the lack of enrollment because parents have a good grasp at what we're doing and they are more likely to then participate in those clinical trials.
So this is all very interesting, but, and I think many people would have been content to do the elegant rat and mouse and preclinical studies that you did, but you mentioned a clinical trial. And so normally at this point, we ask about what's your latest discovery. But I think in your case, from my understanding of your work, it's not so much your latest discovery. It's like this mission that you've been on, and now you've taken this next step. So you took a step and work was done in rats exposed to high oxygen levels to mimic these babies with bronchopulmonary dysplasia, sort of an animal model. And you showed you could cure them by giving stem cell therapy, and you showed the cells weren't staying there. They were giving off chemicals. That's all great. But then you took it to the next level, to the bedside. So first, tell us about that. Was that like a year, 2 years? Was it easy? Was it hard? Are you done? Or is it a clinical therapy?
Yeah. In total, it took 20 years from conception, idea of injecting stem cells to prevent lung injury, to actually doing the first clinical trial. And there were a lot of ups and downs and obstacles, but ultimately we did this first critical step to do a phase 1 clinical trial to test feasibility and safety of these stem cells in preterm babies.
Is that what phase 1 clinical trial means? Is just safety?
Yeah, this is what phase 1 clinical trial means, to test first, is it possible to actually do this? And number 2, is it safe to do this? And we did that in 9 babies. And now the next step will be to do what we call a phase 2 trial, which is test further efficacy in more patients, but also test the efficacy of this approach.
So before we get into the details of the results of your phase 1 trial, I have to just ask you, as a fellow physician, were you kind of terrified to be giving these cells? I know you've given them to baby baboons and rats, and you've done your homework and you looked at the literature, but what was it like the first day? Were you there in the room? Did these cells infuse through an IV? Tell me what the vibe was.
Absolutely. So I think you nailed it. Because we had done this very careful work, including the baboons, which is very close to a human clinical trial, I was reassured about the safety of this approach. But the first patient that we injected these cells intravenously, I was very tensed, even though we had done our homework. And there were a lot of people in the room. One, because, this was a world's first. And number 2, they wanted to see, what is going to happen. And there was a very emotional moment where I was checking that everything was set up well. And then the nurse taps me on my shoulder and said, "Bernard, do you want to start the IV infusion?"
At that point, it would have looked bad if you'd said no. So I assume you said yes?
I said yes, and I started the IV, and I got very emotional.
I can imagine a culmination of a lot of work and probably a lot of adrenaline flowing through your veins at that point. And so there's a bag of cells, and they just flow in through an IV with a filter or something. Is that how it works?
Yeah. So the cells were already in a syringe that was mounted on this automated pump, and we added a filter as an additional safety feature, and everything went well. It's a 15-minute infusion. And everything went well. You could see everyone in the room relaxed. And after the second or third patient, it became really clear that actually this is not different than a blood transfusion, except that we're using a different type of cell.
And so I know you did 3 different doses of cells because you're, again, as a phase 1 study, so you're trying to calibrate what you do ultimately as a therapy. So give us a brief, I presume it's not embargoed. Are you able to tell us what the results of that phase 1 study are?
So again, the endpoints are feasibility and safety. So I can say that this approach is absolutely feasible. And for now, we had no pre-specified acute toxicity during the infusion, and during the hospital stay, nothing out of the ordinary happen to these babies. And an important milestone in those babies is a neurodevelopmental follow-up at 2 years of age. Mm-hmm. And so this is still outstanding in those patients. And that will be an important one. And I believe that in the future, in those efficacy trials, that will be an important endpoint. Even though we're targeting the lungs, I think we will see positive effects on the brain as well.
So hearing all of this, I quickly run out of appropriate superlatives that match it, but pioneering and miraculous spring to mind. This is outstanding that you've managed this. And my next question almost seems to kind of bring that back down, because as scientists, I intimately recognize that for every success that we have, it's built on a huge amount of failure. So can you tell us a little bit about any bumps in the road that you've had to overcome to get to this point?
Yeah, there were major bumps in the roads, and the biggest ones were where do you get the cells from and how do you manufacture them, right? And so there were actually 3 bumps before we got it right. And one was to work through academia. The second approach was to work with industry. And finally, to come back to an academic route to make those cells clinical grade and test them in our animal models, and to finally get to the clinical trial. This is why it took us 20 years.
And it's interesting, we just had Dr. Annette Hay from hematology talking to us about her CAR T-cell initiative, this new cell-based therapy to treat and hopefully cure diseases like lymphoma or multiple myeloma. And she was also talking about the industry model for making cells, which yields effective cells that cost $500,000 for one dose in her case, or what she's doing, leading a national network. And so why did you move back from industry to academia? Was it efficacy or was it cost, or what was the issue?
It was the whole process of trying to make a cell product that would make profit for this industry partner. And so the timelines were just much longer, and it became a very complicated process when I saw that we could go there faster and maybe even better by keeping it small in the beginning and then building it up. And for this particular cell product, we may actually end up without an industry product. It could be like a blood transfusion if these cells can be manufactured in an academic center.
And I think that, another thing we were saying to Dr. Hay yesterday is that there's definitely a made in Canada vibe to some of the conversations we're having. You've made these in Canada, they're being manufactured, and they're not actually in the hands of industry. They're in the hands of academic doctors whose heart is solely placed in, rather than anything else, in curing and treating illness.
Absolutely. And stem cells were actually discovered by 2 Canadian researchers, Till and McCulloch.
Yeah, it's also interesting that, although I'm not a pediatrician, I have great respect for the art of pediatrics. And it's interesting that all these advances you mentioned, like surfactant, mechanical ventilation, inhaled nitric oxide, which we didn't talk about, but these things that keep premature babies alive, they were also done by colleagues like you who basically worked, or even the drugs to close the ductus done at the bedside by clinicians and scientists, or both, who were just working on their own and were innovators driven by this incredible need of seeing a tiny, tiny baby in such distress.
Yeah, it's the passion and the vision of or having the guts to do something disruptive.
Yeah, and I think it takes a lot of courage, especially with a little baby and their parents. But, well, listen, the next question we have is, you've told us about the bump in the road. Now we're going to future visioning. So pick up your crystal ball and tell us, where does this go next? I mean, are these going to be drugs off the shelf in the form of cells? Are you going to use the soup from the cells to cure people? And tell us what's next after the phase 1 trial.
Yeah. So it's always difficult to predict what is going to happen. But I think that we have to go through the same rigorous approach that we used in the preclinical field and now moving to phase 1 trials. So the next step will be to design a phase 2 trial to try to show or to determine whether these cells actually make a difference in the outcome of these babies. And this will be the phase 2 trial. And what I foresee, if the preclinical studies are any indication of what these cells are able to do, what I anticipate is that we will see improvement in the lung health outcome of these babies, but also in their neurodevelopmental outcome. And this is really the beauty of this approach, that it will target the lung, but it will also have ancillary beneficial effects on other organs, so that overall outcome of these babies will be improved. And that would be a true major breakthrough if those phase 2 trials can prove that these cells work.
And is that because the oxygen these babies are getting with the mechanical ventilation to save their life is not only toxic to the lung, but it's also toxic to the brain and the kidneys and other organs? Is that, and then the cells are releasing products which are going to these other organs in addition to the lung? Is that the idea?
Yeah, that is the idea. We believe that the oxygen that we provide is also toxic to other organs. And because the lungs are sick and we need to give more oxygen, and there's inflammation happening in the lung, but then this inflammation can also affect the brain and other organs. And by attenuating all these different mechanisms, including inflammation, these cells will have not only lung effects, but also systemic effects on these other organs.
And I know, Charlie, I'm going to turn to you because Dr. Thébaud was giving a lecture, and he seems to be deeply buried in the Marvel universe, which you know more about than I do. So maybe you can ask him about his future clinical trials and what this penchant is for the Marvel universe.
Yeah, well, I think you've just asked the question wonderfully. You know, what's your interest with the Marvel universe? Is it just a useful tool, or do you just like to geek out?
Or do you live there?
It is. Yeah, it's. I think it's to show that you can be a superhero, but also the real superheroes are our patients. And by giving those names to those trials, so the trial that we were talking about is the HULK trial, helping underdeveloped lungs with cells. And it motivates also the troops, the basic scientists that work in the lab, the clinicians, the nurses, the respiratory therapists that participate in the clinical trial. It's very motivating, I think, to say, yeah, we participated in the HULK trial, or we're doing the HULK trial.
I think it's very accessible as well. All of a sudden, everyone sort of has some link to it, and it's not a scary acronym all of a sudden. It's something that's comfortable. HULK. Oh, nice.
And who follows HULK? After HULK comes who?
So after HULK, so here the trials will be HULK 1, HULK 2, but we have some other disruptive therapies in store that we're still working on in the lab, but that we hope will see the light in the clinic over the next 5 years. And so there's Iron Man, and there is the Avengers. And
you're going to have to as time goes on, you're going to have to increasingly work harder to fit the science to the acronym.
The Iron Man is a complicated acronym, but it fits perfectly.
It works.
Yes, it works. And the Avenger is also a nice wordplay on this gene therapy that we're trying to get into the clinic. And I hope that these will be successes, just like hopefully HULK will be.
Excellent. So thank you very much, Dr. Thébaud, for taking time to speak to us about your pioneering clinical and work and your research. And before we wrap this podcast up, we'd like our audience just to get to know a little bit about you as a person, about the person behind the research, about who you are. So we've got a few more fun questions that we can ask, so you can relax now. All the hard work's over. My first question I'm going to come right out the gate with is, you've obviously worked with Dr. Archer before. In fact, I believe that he was your mentor. So if you have one opportunity to tell a story that would completely roast him on this podcast, I'm happy for you to tell that, and it may or may not get cut.
So absolutely, Stephen is my mentor, and he's a great mentor, and I see myself applying some of the principles to my mentees today. And I think the best story happened actually just 1 month ago when we were both at a conference in San Francisco, and Stephen gave a talk, and I was going to follow him. And of course, often if you hear a great talk and then you have to speak after this person, it's a real challenge. And so I get up to the stage and I say, it's always a hard act to follow, especially your mentor. And everyone expected a compliment. And I say, yeah, because now I have to wake up the room.
And I would say, having been in the room, he got a very sustained ovation and laugh. I was speaking on metabolism, so he probably was literally waking up the room after I finished. Brilliant. So my question is related to your former football, soccer loving self. If you were to go back and talk to yourself when you were at that stage of your life, when you were a teenager, is there any advice you'd give your teenage self about how to live your future life?
I think this was an exciting experience, which at that time didn't realize would prepare me for all the hardship later on in life. Because through soccer, you really learn competitiveness, dealing with adversity, and I was also passionate about this sport. Like, no one had to tell me, Bernard, you like go to practice. I practice even outside practice because I love that sport so much, right? And so I understood what it meant to be passionate about something. And later on, when I moved on to medicine, I was a little bit worried about how I would practice the medicine, because in soccer, I had talent. In medicine, I didn't perceive a particular talent or an Einstein brain, for example. But I realized that I was passionate about medicine and about my patients. And I think that was very insightful. In retrospect, I realized that, yeah, passion is an important driver, and just follow your passion. And then you will not have the impression that you're actually working. You're doing what you're passionate about, what you like.
So I'm going to avoid the urge to just spend the rest of this podcast talking about football. But I will ask you, do you still play football?
I had to stop 5 years ago because of a knee injury, but I had stopped playing around 26 when I had to prepare for the exams to become a pediatrician. And when I came to Canada for the postdoc, so then I was 35, I said, hey, I don't have night calls, I don't have clinical duties. Why don't I start playing soccer again? And I thought, yeah, I would play. Now that I'm a physician, I'm much more relaxed and have some wisdom. But once I was on that green rectangle, the same passion came back, and I just.
Last football question, I promise. No, well, we can continue later, but who do you tip for the upcoming North American World Cup, which I'm super excited that I'm going to be around for, but who are you tipping to win?
To win? It's too early to say. I think
so the answer was England, obviously.
Exactly. So England has a very interesting team, an exciting team. When you look at the quality of the players, they should be under the the top four. France, obviously, will be there. And then Brazil, I think, will make a reappearance. And Germany.
Dr. Thébaud, we've had a little bit of a conversation about the Marvel Universe and about the Avengers. One thing we often ask researchers in this podcast is, what's your favorite cartoon character? And what cartoon character do you think best represents you? But obviously, I'm going to restrict this to the Marvel Universe and ask, which of the heroes you resonates for you?
Black Panther.
Excellent. And why? Tell me.
I love the animal. and because it's very athletic, fast, and unexpected. And Black Panther, I love what they did was the newest movie.
Yeah, both movies were great.
And yes, and I liked the main character in the first movie, and so I could really relate to that.
I'm so relieved that you picked Black Panther, because for those of you listening to the podcast who don't know the relationship Bernard and I have, for the first 15 or 20 years, his favorite cartoon character was the Smurf, or I think they're called Strumpf in German, right? And so I'm glad you have moved on to a slightly more prestigious and sexy cartoon character.
I love the Smurf because they're blue, and we try to turn our babies into pink. And so that was a very illustrative way of trying to showing what we're trying to achieve.
Well, Papa Smurf and myself both appreciate your
That's right. I'm over mentoring.
Dr. Thébaud, on behalf of Dr. Archer and myself, I'd like to thank you very much for coming in today and giving us the opportunity to get to know you, and also your research and your clinical practice, and how you're bringing Canadian-made therapeutics to neonatal medicine care right here in Canada. If you've enjoyed this episode and would like to know more about Queen's University Translational Medicine, or share this podcast with somebody else, you can search for Time to Talk Science and Medicine wherever you normally look for podcasts. Thank you very much.